Bismillah ar-Rahman ar-Rahim. Our case today is very interesting. This baby full term, early term, 37 weeks, delivered by cesarean sections, vigorous, good upper score, systemic examination within normal, baby impression. It is early term, 37 weeks, RDS to rule out early onset neonatal sepsis, baby admitted to NICU, septic workup taken, started antibiotic ampicillin gentamicin. Then we request chest X-ray. This is the chest X-ray. As we know, there is classic picture of the RDS, decreased lung volume, diffuse ground glass appearance, and air bronchogram. It can happen in the full term. RDS can happen in the full term. Yes, it's common in premature babies, but can happen in the full term babies, especially in there is perinatal factor or perinatal asphyxia, if there is cesarean without labor unplanned, and the third reason, it will surfactant deficiency, especially for IDM babies. It decreases surfactant function rather than senses. Due to hyperinsulinism, it will give you picture of the RDS. So it can happen in the full term if there is perinatal factor, cesarean without labor, and IDM babies due to surfactant function defect rather than senses. If you see here, this is the X-ray. Actually, the most important finding here, the ETT is high. The ETT high. It's above the carina. Actually, it should be between T1 and T2 vertebrae, but actually it's high. Sometimes maybe because the baby is asymmetrical or not centralized. So our concern here, what is the complication of ETT high? If the ETT, if you left the ETT high position like that, what will happen to the baby? What will happen to the baby? There is 6 or 7 finding it will happen to this baby if you left this baby ETT high like that. The first thing, accidental extubation. Accidental extubation. The baby actually it leading, especially during the handling or repositioning or manipulation of the baby, lead to sudden respiratory failure or sudden deterioration due to accidental extubation. Accidental extubation. This is the first. The second, ineffective ventilation, inadequate delivery of the tidal volume due to poor ETT placement above the glottis. Lead to what? The tidal volume delivered, it will be inadequate, leading to ineffective ventilation. The third one, airway obstruction or malposition. The ETT tip may rest near or in the pharynx, causing what? Partial airway obstruction. Partial airway obstruction. This is the third one. The first, accidental extubation, ineffective ventilation. The third one, airway obstruction or malposition. The fourth complication, because the tube is high, it will be increased risk of aspiration. If the focal cords are not bypass, the aspiration of secretion is more likely, leading to aspiration. The fifth complication of the ETT is high, inconsistent oxygenation and CO2 clearance, lead to what? Hypoxia and hypercapnia. If you do blood gas, there is hypoxia and hypercapnia. The sixth complication for ETT high, focal cord injury. The tip, actually, it will irritate the focal cord, especially if the ETT is repeatedly moving and malpositioning. Moving and malpositioning, it leads to vocal cord injury. The 7 reasons or complications of the ETT is high, delay recognition of the tube, actually delayed recognition, especially in emergency situation, or if the imaging is not proper reviewed. If the image is not proper reviewed. So the complication of high ETT, first, accidental extubation leading to sudden respiratory failure, ineffective ventilations because the tidal volume delivered, it will be inadequate. The third, airway obstruction or malposition. The fourth, increased risk of aspiration. The fifth, inconsistent oxygenation and CO2 clearance, leading to hypoxia and hypercapnia. The sixth, focal cord irritation, delayed recognition, especially in emergency situation, and or if imaging is not proper actually viewed. But what are going to do? The solution. This is the problem. What is the solution? The solution, the first one, or the prevention and management. First, you have to fix the ETT in the proper position, and you have to know this is improper by clinical assessment. There is chest rising, breath sound. So the clinical assessment, you know this is the ETT in the proper position, the chest rising and the breath sound and effective ventilation. The second, proper depth, tip to lip. It will be especially the depths of the ETT, it will be 6 plus the weight of the baby, or the tragus to nasal length, tragus to nasal length. The third one, you have to secure the ETT properly to prevent migration or accidental movement. The fourth, frequent monitoring and recheck after repositioning if there is any clinical deterioration, So how to prevent this event, high ETT? You have to confirm the placement, use the clinical assessment, your clinical chest rising and breath sound. You have to proper depths, tip to lip, it will be 6 plus the weight, or tragus nasal length, and secure the ETT to prevent migration or accidental movement. The fourth, frequent monitoring and recheck after repositioning or there is any clinical deterioration. ومن أحيا فكأنما أحيا الناس جميعا. شكرا، سلام عليكم.